Okay, welcome. Good morning, everyone, to the Grand Rounds at the Semel Institute at UCLA. It is my great honor to introduce our speaker for today, Dr. Brandon Yarnes. Dr. Yarnes is a colleague of mine at the West LA VA, Greater Los Angeles VA. He started out his education in Arizona, getting his bachelor's at Arizona State, wandered a little bit further to the east, going to the East Carolina University for medical school, got his residency in New Mexico, and then somehow wound up at Yale doing his geriatric fellowship. But he saw the error of his ways and came back to UCLA for an advanced fellowship as a UCLA VA National Clinician Scholar, and then got a master's in health policy and management at the Fielding School of Public Health at UCLA. Finished all of that in 2017 and immediately started being nominated and winning teaching awards. He got let's see, I've skipped over here with the teaching awards. He was the nominee for Outstanding Teaching Resident or Fellow for the Department of Psychiatry and Biobehavioral Science there in 2017, and was Faculty of the Year for the UCLA VA Psychiatry Residency Program this past year. In the meantime, though, he's also been very busy professionally. He's the founding chair of the Early Career Psychiatrist Caucus of the American Association for Geriatric Psychiatry, the chair of the Scholars Program for the American Association for Geriatric Psychiatry, and has been also in, as we said, very involved with the National Clinician Scholars Program. What he has done is managed to move on from the National Clinician Scholars Program to the initial grant, the Beginning Scholars Pilot Grant, to an Optimizing Outcomes in Treatment Resistant Depression in Older Adults, to now having a grant, the VA Career Development Award grant that goes through 2024. So it's been great fun to watch him skyrocket over the last few years at the VA, and also to adopt a number of our residents to teach them also intensive short-term dynamic therapy, but also how to work in therapy with geriatric patients, particularly having to do with pain. So we are delighted to welcome Dr. Yarnes today.
Thank you very much, Dr. Stuber, for that very kind introduction. And thank you all for joining. So I'm going to talk to you today about my work, with emotional awareness and expression therapy, which is a psychotherapy for chronic pain. EAET is the acronym. But before I started with that, I just wanted to mention for a moment that over the weekend, my dad did pass away. His name was Bob Yarnes, and he was my hero and my best friend. And I'm here today in my career and for this presentation, largely because of him and his inspiration and influence. And I know he would want me to go ahead and do this presentation that I put so much work into today, but I just wanted to dedicate this presentation to my dad. So thank you very much. So now returning to emotional awareness and expression therapy. As Dr. Stuber mentioned, I have a VA Career Development Award to study EAET, which is like a K award but it's funded through the VA. And I'm also site PI for a couple of clinical trials supported by NIA and PCORI. And so these are the learning objectives for my talk today. These symbols also kind of indicate the outline roughly of my talk and also the outline of my research career ambitions. So the way I would like to study chronic pain and EAET over the coming years and decades. So first, I'm going to talk to you about the big role that the brain and emotional experience and expressions. You can see this guy here with a lot of emotional expression, how they influence chronic pain. And not only just to regulate and modulate chronic pain, which you're probably aware of, but actually to generate some forms of chronic pain. Then I'm going to move over and talk about some of the clinical research that I've been working on and others have worked on about outcomes of psychotherapy for chronic pain from standard psychotherapy approaches and also this unique approach, EAET, that I'm going to talk about. And then at the end, after I've talked to you about these things, I think you may see that there is a potentially greater role for mental health providers generally and for EAET specifically in the treatment of chronic pain in healthcare systems such as the VA, where I work. So I'm going to start here with a case, and it's not my case. This case was published in BMJ in 1995, and I found out about it in Howard Schubiner's book, Unlearn Your Pain, which I highly recommend. So here's the case. A 29-year-old construction worker was brought into the emergency department. He had jumped off a platform in the construction site and gotten this nail here through his boot. And he was in so much pain, so much distress, that they actually had to sedate him with fentanyl and midazolam in order to get the boot off. So they removed the boot, and guess what? The nail actually didn't pierce his skin. It was stuck in between his toes when they got the boot off, and there was no tissue damage at all. But this is very important, and this is what we emphasize with all our EAET patients, that the pain he was feeling was real. He was actually feeling pain. He wasn't making it up. He was feeling pain. But the question is, what was the cause of his pain? And it was not caused by any damage to his tissue in his foot. It was caused by the brain and emotions. And that is really fundamental to emotional awareness and expression therapy, which was developed in the early 2010s by these guys, Mark Lumley and Howard Schubiner. And you can read this article from Current Rheumatology Reports in 2019 about the development of EAET and the rationale behind it and early studies, which I recommend. And the basis of it was that many types of chronic pain have involvement of the brain and emotions. And these are called medically unexplained pain or centralized pain. Another word is nociplastic pain. And it's conditions like fibromyalgia. Fully 2/3 of the patients with chronic low back pain, other regional pain syndromes, and also things like irritable bowel syndrome that involve the brain and emotions. And this kind of psychotherapy was developed to treat it. So EAET just comes from a wide range of different theoretical traditions. It's an integrative psychotherapy. I'll emphasize a couple of points here. So one of them is pain neuroscience. So we teach patients in EAET about the relation of brain and emotions to chronic pain. The same stuff I'm about to teach you, we teach the patients in a form. And one of the other inspirations is intensive short-term dynamic psychotherapy, or ISTDP. EAET shares a conceptual model with ISTDP. And that's how I came across EAET. I wanted to empirically study a format of ISTDP, and I was looking around, and one of my mentors and supervisors, Patricia Coughlin, actually introduced me to Howard. And that's how I came across EAET in 2017, and the rest is history. And so it incorporates multiple different modalities, but has this conceptual model, which I have developed this slide to explain. So here's the deal. So in our lives, we have stress, we have hassles, we have conflicts in relationships, we keep secrets, some of us have trauma, and all of these experiences create emotions in us, difficult emotions for us, like anger, like emotional pain, grief, and guilt. So the key is how we have learned how to deal with our emotions. So if we're scared of our emotions and we avoid them through the habitual use of defenses, then EAET asserts that that is the way that we develop pain, some other symptoms, these other centralized conditions, and that is associated with brain changes. If, however, we accept our feelings, even difficult ones, we feel them and then let them pass, then that's how pain is reduced and symptoms are reduced and there's normalization of brain activity. And that's really where EAET comes into play. We help patients experience and face the emotions that they have been avoiding, and we hope that that results in reduction of pain and normalization of brain activity. And I think there is a lot of empirical support for that we've been working on. So how about this conceptual model? Is there any kind of data or research that supports aspects of this conceptual model? And so I'm going to review next some of the research that we, again, sometimes communicate to the patients about how the brain and emotions affect chronic pain. And the notion that the brain and emotions affect chronic pain goes back at least to Melzack and Wall's gate control theory of pain from 1965, although they note in the article that people as far back as Descartes were noting a role for the brain in pain. And Melzack and Wall, though, said that the central nervous system modulates and regulates the experience of pain always. And that includes the spinal cord, but also the brain, and particularly emotional brain centers. And this is consistent with recent definitions of pain. The modern definition of pain by the International Association for the Study of Pain defines all experiences of pain as a combination of sensation and affective experience or emotional experience. So they say it's both. So how about neuroimaging support for an emotional component of pain? So neuroimaging studies, really now for several decades, have taken healthy adults, pain patients, and they induce acute pain inside the scanner with tasks like mechanical pain stimulation. They will pinch your thumb most often until it hurts, or thermal pain, painful heat or cold. And when pain is induced in the scanner, there is an activation of both sensory brain regions, most commonly thalamus and secondary somatosensory cortex, as well as emotional brain centers like the insula and the dorsal anterior cingulate. So acute pain is both a sensation and an emotional experience. We're pretty sure about that. But we're here to talk about and how to treat chronic pain. So what about chronic pain? People have tried to come up with paradigms for neuroimaging studies to look at how chronic pain registers in the brain. And so the Apkarian group at Northwestern University, they've developed several different paradigms to look at chronic pain, and these all involve those medically unexplained chronic low back pain patients. So in the first experiment, they took chronic low back pain patients, put them in the scanner, and they didn't produce any kind of stimulus or induce pain, but they just had the patients rate their spontaneous fluctuations in pain, how they were feeling their pain in their back as they were laying in the scanner continuously with a dial. So their pain would go up and then it would go down, and they were rating this constantly. And they found when spontaneous pain was high, there actually was activation only of the emotional brain centers, not any sensory brain regions. And they were slightly different than in acute pain. They were activations in the medial prefrontal cortex and the rostral rather than the dorsal anterior cingulate. So these are regions that are involved in a wide range of functions. Medial PFC is part of the default mode network, but also more interesting things like emotional conflict, and they're involved in moral dilemmas, moral decision making. And then also activation of the amygdala, which is involved in emotional experience, especially fear, and the striatum, the nucleus accumbens, which is involved in reward. So in this spontaneous chronic pain, although the patients were feeling physical pain in their back, what you get in the brain is emotional brain activation. So in the second experiment, they had pain patients, chronic low back pain patients, and healthy patients. They put them in the scanner and had them do a simple visual attention task. And they found that there were differences in the two groups when they transitioned from the task negative to the task positive in the medial PFC. And these pain patients actually had what you might think of as an abnormality compared to the healthy controls. They had reduced deactivations. So in plain English, my interpretation is they not only have chronic pain activates the medial PFC, but they also can't turn it off. And this is despite having task performance that was the same as the healthy controls. So finally, the Abkarian group, they did a longitudinal study. They took patients they called subacute back pain patients, patients that had had chronic pain or pain for 4 to 16 weeks following an injury. And they followed these patients for a full year. And they determined that after the year, patients' pain either remitted or it persisted and transitioned into chronic pain. And they found that actually connectivity between the medial PFC and the nucleus accumbens was the best predictor of the transition from acute to chronic pain, the persistence of pain compared to the nature of the injury, pain characteristics, or drug therapy that the patients had received. So again, there's a lot of support from this work that these emotional brain centers are very important for the experience of the pain. There are changes, brain changes, particularly in these emotional brain regions with chronic pain, and they actually are a predictor of chronic pain. So very important, the brain changes and emotions to chronic pain. But all of this is about what is pain and chronic pain like in the brain. So in emotional awareness and expression therapy, what we do is try to activate healthy emotions, help patients face and experience emotions that they've been avoiding besides pain. So everybody knows that emotions are in the brain. But what you may not know, what I didn't know until I started studying this really in my intellectualized way of doing things, is that your feelings, emotions are also in the body. So in order to experience or be in touch with a particular feeling, the psychological theory behind EAET and also other psychological theories from different disciplines within psychology says you have to experience at least 3 components to be in touch with or experiencing a feeling. You have to be able to name the feeling, to be able to feel the feeling in the body, and then be aware of the impulses or action tendencies of the feeling. I'll talk a little bit more about that in a minute. So each of these feelings that we review in emotional awareness and expression therapy, which involves healthy anger, grief and sadness, guilt, healthy guilt, and love and connecting feelings, positive feelings, each of them is supposed to thought to have prototypical bodily sensations. And this actually has been supported with empirical research. So these researchers took over 1,000 healthy adults and they had them report where, if anywhere, they experienced different feelings in their bodies. And the patients or the healthy adults did report that they felt their feelings in the body and that different feelings felt differently. So we really emphasize this when we're administering emotional awareness and expression therapy, that we have the patients feel these healthy feelings and get them feeling it in the body. So their pain is in their body and emotions are in their body. And a lot of these patients, we observe they're kind of stuck on just feeling pain all the time. So we think if we can help them feel other things in their body, then we can move them away from just feeling pain all the time to where they're feeling healthy emotions. And then this third component is something we also review. It's called the impulses or action tendencies. So each of these feelings, like healthy anger, may be associated with healthy impulses to say no to people, to set boundaries with people, or to assert yourself. So we teach the patients these healthy action tendencies or impulses that are associated with their feelings to try to help them to get more in touch with their feelings. And so that is going to become important in a moment, because what we're talking about here is feelings are in the body, but do these experiences of feelings in the body result in brain changes that may help improve chronic pain? And really, that's not entirely been determined yet, but that's something that I'm interested in working on in future research. But there is one very interesting neuroimaging paradigm that I'm going to get to in a minute. But there's a lot of empirical data showing that different ways of experiencing different feelings and avoiding versus accepting and being aware of feelings does affect chronic pain, and in particular, anger. So this figure is from a review article I've been working on that's under review at Neuroscience and Biobehavioral Reviews right now with my colleague, Amy Jimenez at UCLA and the VA. And it shows that different ways of dealing with anger affects chronic pain for chronic pain patients. So the experience of anger here, the greater your anger, the more your pain increases. And also suppressing or inhibiting or avoiding anger in different behavioral paradigms causes pain to increase for these patients. On the other hand, becoming aware of anger, and that includes having all these thoughts about different impulses or action tendencies or what the anger makes you want to do, also actually regulates anger, reduces state anger, as well as reducing pain and muscle tension. So I've been thinking now, I've been talking for 20 minutes, and I've been thinking about how do I incorporate an experiential exercise into this talk, because the EAET is very experiential. So in this first paper here, what they did was they took healthy adults and they had them do different yoga poses. They did an aggressive dominant yoga pose, and they did a submissive passive yoga pose, and looked at their pain thresholds when they were doing different yoga poses. And they actually found that a healthy, dominant, aggressive yoga pose was resulted in a higher pain threshold for these individuals. So it did affect pain. So you've been sitting here for a while, maybe your back is starting to hurt. So why don't you get into a dominant position, sit up straight, put them up here. This is the kind of thing we do with our patients, and take on a dominant pose, like put them up here, maybe give a rrr. And how does that feel? Do you feel strong? Do you feel powerful, energized? That's the kind of thing that we do with our patients, teaching them these healthy emotions so they can feel more powerful and stronger and energized and less in pain. Now, I mentioned a moment ago that there's not a lot of neuroimaging data yet in chronic pain patients that looks at how emotional experiences affect pain. But there is one very interesting paradigm that I've been looking at, and that is looking at imaginal aggression, which is investigating these aggressive action tendencies that I've been talking about with healthy anger. And the first two here, Petrini and Strinziak, that I have listed, what they did was they put patients, healthy adults actually, in the scanner, and they asked them to imagine a situation where they were being mugged or robbed in an elevator or parking garage, and they would react with a healthy or righteous angry response, like fighting the guy off, standing up for themselves. And then in the third paper by Dr. DeCidi, they viewed images and they said, imagine you're in this situation where you're having to defend yourself and you actually hurt someone else. That's a very key thing. And what happens in the brain there. So this is an example of one of the stimuli that we use. So viewer discretion advised here. So it's again, somebody's trying to reach in your window and you take that and slam their hand. So it's this healthy anger response, this healthy righteous anger. And what actually they showed is that it's the opposite pattern of what we found in chronic pain. There is a strong and significant deactivation of the medial PFC if patients imagine themselves with this healthy anger response, and there's less activation in the amygdala. And you'll recall that in chronic pain, we had activations and reduced deactivations of the medial PFC and also the amygdala in chronic pain. So this is just hypothesis generating. I'm combining these literatures, but I do intend to do a pilot study. I have gotten pilot scan time at the Staglin Center for Cognitive Neuroscience to do this imaginal aggression paradigm in chronic back pain patients and healthy patients, and see, my hypothesis is that the chronic pain patients will have reduced deactivations in the medial PFC, which may further help us to understand the etiology of chronic pain in the brain, and then see if we desensitize them to their anger, get them feeling their healthy anger again, if these pathways can normalize. So uniting the brain and the emotion, but that's yet to come. So now I'm going to summarize this neuroscience section. Your head's probably spinning. I've been going pretty fast here. But what we have, this is the rationale, the basis for EAET is that pain and emotions have representations both in the body and in the brain. And that emotions and emotion regulation, especially I reviewed anger, affects the presence and the severity of chronic pain. So now I'm going to transition into talking about some clinical research. So if emotions and the brain are so much involved in chronic pain, then you would think mental health could have a big role in treating chronic pain. And indeed, you've probably all prescribed duloxetine for chronic pain patients, and you have a lot of chronic pain patients in your practice. There's also been psychotherapies that have been developed for chronic pain prior to EAET. And the gold standard in the VA is CBT for chronic pain, which has been nationally disseminated in the VA healthcare system. And it's a great treatment. And last year, the developers of this manual published data on 1,331 veterans who have received CBT for chronic pain in the VA. And what they found was CBT had pretty good effects on what's called pain catastrophizing, which is worrying about your pain, like, oh, my pain's never going to go away. That improved to a moderate to large effect size, as well as pain's interference with your activities or with your mood. But they actually found less reduction of pain itself through CBT for chronic pain. Depending on how they asked about pain, it ranged from a small effect size 0.2 up to about 0.65. And another issue was only 58% of the veterans actually completed. So there were a lot of dropouts from this program. And what about other popular approaches? So ACT, acceptance and commitment therapy, has been studied in a large trial where they compared it with CBT, and they found really no difference in any outcomes at any time point. And then finally, another popular treatment, mindfulness-based stress reduction. There was a large 3-arm trial, over 300 patients, randomized to usual care, CBT for pain, or mindfulness-based stress reduction. And again, even following them out to 2 years, they found no differences in CBT from chronic pain and mindfulness. And I wonder if there's not as strong an effect on especially pain reduction in these treatments, because there's not as much focus on the neuroscience and emotions and emotion regulation as we do in EAET. So let's look for comparison at some EAET outcomes. So I'm going to just briefly mention 5 studies that were performed by the Lumley Group, the developers of the intervention, early on. And they first tested a one-session EAET in 75 individuals with medically unexplained symptoms, mostly pain. And they also tested it in 62 women with chronic pelvic pain and found that it had stronger effects on pain reduction, interference, and other outcomes than a weightless control. So they then kind of did a wild card here. They applied a 3-session EAET to irritable bowel syndrome. And in this study, they found that EAET improved irritable bowel syndrome, but no more than a relaxation control, although both outperformed a waitlist. And then finally, they looked at an 8-session group-based EAET for 230 patients with fibromyalgia, which was an R01 funded study from NIAMS. And they found that EAET outperformed CBT for fibromyalgia patients on several critical outcomes, including reductions in widespread pain and also the number of patients who had a large response of greater than 50% improvement in their pain, which is very small. It was about 8% in CBT, but about a quarter of the patients had a large reduction in pain with EAET. So some differences there with CBT, especially on pain reduction. So then I started a pilot study in my population of older veterans. So I am a geriatric psychiatrist, as Dr. Stuber mentioned. So in my studies of EAET, all my patients are older than 50 or older than 60. So initially, after I got the EAET manual, I just started doing this in a pilot study, and I compared EAET to CBT for chronic pain in veterans aged 50 or older with a wide range of musculoskeletal complaints, including fibromyalgia, tension headaches, chronic low back pain, or other regional pain syndromes. And I randomized to either EAET or CBT for chronic pain, which was delivered as a 9-session, so the biggest number of sessions of EAET. And it was one individual session followed by 8 group sessions in groups of 6 to 8 veterans. And we collected self-report outcomes at baseline, post-treatment, and 3-month follow-up that covered pain, pain interference, mood, anxiety, and other outcomes. And in this study, EAET involved psychoeducation. I mentioned pain neuroscience, but there were also lessons about different healthy emotions, healthy empowering feelings like anger and connecting feelings, guilt, and other lessons in each session. There was also experiential activities, which I mentioned. So one of them was just getting them to feel different feelings in their body, starting with anger and with love or connecting feelings. Then the key intervention was this thing called experiencing, expressing, and releasing feelings in relationships. And we don't actually have them do it in the relationship. They do it in the office, in the session. They will pick a stressful event in a relationship, and we will examine all of their feelings, have them feel the feelings in their body, examine the impulses or action tendencies with the feeling, and see how that affects their pain level. See if feeling their feelings helps them reduce their pain during the session. And then we also had activities related to healthy communication, feelings, and this was augmented by written homework assignments that looked at lifelong patterns of how they avoided or faced different feelings and how that was temporally related to their symptoms and pain, and then also written emotional disclosure, which Mark Lumley had studied extensively, and that augments EAET in most formats. And so we included an older veteran population in this pilot study, which has been published last year in Pain Medicine. There were 28 EAET participants and 25 CBT participants, and these were the results on pain reduction. So there were large effect size and significant differences favoring EAET compared to CBT at post-treatment and 3-month follow-up. And so you see here that the red line is EAET. That's the magnitude they went down. And then they continued to improve a little more into follow-up. Whereas the blue line represents CBT, which is very similar to other studies, that there's a small improvement in pain at post-treatment, but pain really goes right back up to where it was during the follow-up period. And just to make the point with pain reduction again, these are the individual patients. This was in the paper if you want to look that up. And so the dot represents their baseline pain score on 0 to 10. And then their the end of the arrow is the post-treatment pain score. So you can see the longer arrows are greater magnitude reduction in pain. And that didn't occur for every EAET participant, but it occurred a lot more than the CBT pain patients. And there were bigger effects in some patients, like this patient here that had greater than 70% reduction in their pain. And interestingly, if you're wondering, the pain interference scores were a little larger for EAET, but it was not quite significant. So pain's interference with mood or with activities favored EAET, but the p-value was 0.051 at post-treatment. So what I did next was I got this VA Career Development Award, which repeats this design in a larger sample of 160 veterans. And by March 2020, we had completed 2 rounds of this larger study. And then everybody knows what happened at that time. So what we did, we tried to figure out, how do we do this? We've got groups of older patients with medical comorbidities and chronic pain. So we tried using these clear masks so you can see the emotional expressions. Like I've demonstrated a couple times, it's really important. And we tried having groups outside, which was kind of a disaster. You think we've got great weather in Los Angeles, but it rained one day, and one day we tried to do a group and it was way too hot. So that didn't work really well. So everybody said, Brandon, you've got to put the groups online. But again, we have older patients, and there really was no data that an intensive emotional experiencing intervention was effective online. There was one study only of intensive short-term dynamic psychotherapy, which I mentioned, that was delivered over Skype. And they actually found it was inferior to in-person treatment for chronic pain. So I said, I only have one paper and it's negative. So I'm not just moving my study over to online, but I'm willing to do another pilot study. So I got a separate grant to do 3 groups of EAET online over Zoom. So we got older veterans and we trained them. We sent them a tablet. We trained them how to use it. We sent them this color technology training manual, which showed them how to operate the tablet, connect to Wi-Fi at their home, and access Zoom and the online assessment platform. Then they all got 9-session EAET, and they completed self-report assessments on the tablet. And this is hot off the presses. This is just the baseline and post-treatment data from the 3 groups that we tried. We're still doing follow-ups, so this has not been published or anything. But you see over here, the first group had 4 veterans, the second group had 6, and the third group had 6. Our mean age was over 70. We actually had 2/3 Black participants, and they started with a pain score about 5.5 on a 0 to 10 scale. And you can see here that the mean pain reduction was actually over 50% pain reduction. We had one guy with 100% pain reduction and 2 people with greater than 90% pain reduction, and everybody improved on this except one guy. You see the 0 there. Unfortunately, he had cognitive impairment that we didn't detect right away, and we felt like he didn't remember from week to week the sessions, but everybody else improved. So it surprised me that doing EAT online, even in a group, even in older patients, still seems to be effective and can reduce our patients' pain, and this should be subject, of course, to a larger RCT. And finally, there was a third group that has recently started studying EAET in Sweden Daniel Marodi and Robert Johansson here. And they did kind of an online self-help version of EAET. They put the worksheets for EAET online, had the patients go through them themselves, and they had 20 minutes a week of therapist contact over email only. And this was in 52 patients with somatic symptom disorder. And they found large effect size improvements in their somatic symptoms at post-treatment and at 4-month follow-up. So that's another interesting modality that can be used potentially to help people with EAET. So there are some limitations of EAET, which I have alluded to. It is difficult. We're asking patients to face the most difficult things in their lives, the most difficult feelings that they've been avoiding forever. And not every patient wants to engage in this process. And I think that's maybe why a lot of the patients that don't improve may not get the kind of benefit that other patients can. Also, these mechanisms, I explained a lot of the neuroscience, but there hasn't been very many studies looking at biological mechanisms, a couple of studies looking at psychological mechanisms. We also don't know which format is best and where EAET may fit in the whole chronic pain algorithm. Should every patient get this at first, or should it be reserved for more treatment-resistant patients? But there are a lot of strengths that we've alluded to. Pain can be reduced with this approach, which is in qualitative and survey data. That's what veterans with chronic pain want. They want their pain to be improved. Pain interference also improves. There's much lower attrition in our studies. I think my pilot study had the most dropouts. I may be wrong about that, but it had 85.7% completed it. And it's been tested in multiple formats now and age groups. And editorial actually referred to it as the treatment of choice for centralized pain. And there's a recent guideline referring to EAT as an evidence-based treatment for chronic pain. So I think you can see that if we want to tackle chronic pain, I think there is a bigger role for mental health providers, and others have called for this in recent years. And mental health providers are in multidisciplinary pain groups, mostly to address opioid use disorder that is comorbid with chronic pain, and these other comorbidities like depression and PTSD that run with chronic pain. But perhaps mental health providers in the future could be involved in actually addressing and treating chronic pain itself. And recent guidelines from CDC and the VA suggest that there should be a biopsychosocial assessment for chronic pain patients and early involvement of mental health providers, and also non-pharmacologic treatments like psychotherapy for chronic pain in the pain algorithm. So it seems like there has been some shift in the paradigm to involve more mental health care providers. But I recently worked on a paper with a couple of my outstanding VA residents, Wei Lo here and Alex Trofimenko, and we looked at the NHANES data set, and among opioid users, people on chronic opioid therapy, really only 18% had seen a mental health care provider. So it seems like although guidelines are changing, the paradigm is shifting, we haven't quite caught up yet in practice. So next steps and future directions for me, I mentioned I'm going to work on that fMRI pilot, which hopefully we'll be able to apply before and after EAET. I would like to finish my clinical trial, stay involved in clinical studies. I do have a grant currently under review in the VA to study the online Zoom-provided EAET and compare it to other treatments. And then I would also like to have as future direction more involvement in health services, looking at mental health care utilization among pain patients, and really push for, advocate for a paradigm shift that I hope you see now that the brain and emotions are fundamental for chronic pain. The brain is really the organ of pain, more so than peripheral tissues and the peripheral nervous system and musculoskeletal abnormalities, which are often found to be incidental and unrelated to where the patients actually feel their pain. And so I would like to thank more people than I can fit on one slide. So these are all my acknowledgments, everybody who's supported me to get to this presentation today. And please email me. My email is here if you have any questions. And with that, I will transition to answering your questions now. Thank you very much.
Thank you very much for a great presentation. I had a number of questions. We did
Sure.
get about 10 questions that were presented to you. One of them was, when you're working in the educational part, do you show the actual scans to the patients to have them see what is happening in their brains?
Well, you mean the particular patients? Do we scan their brains as part of the treatment?
Well, I guess you're not doing that as yet, but so you
Right.
show other people's scans as part of the education?
I haven't actually done that. I think that's a great idea, but we do teach about the brain is involved in pain. We present cases of people who've been successfully gone through this program and had pain reduction. And so I could definitely see that that would be a useful technique if necessary, because patients come in often, you might expect, pretty skeptical about this. And they say things like I mentioned at the beginning, are you telling me I'm making up my pain or it's all in my head? I would say, no, no, no. And Howard talks about one patient who said they realized, oh, what you're saying is the pain, it's not in my head, it's in my brain.
Right.
That's an important distinction that we get. And we really think once we get over that hump where patients are buying in and willing to engage, we have that therapeutic alliance about here's what we're going to do, this is the way we're going to work to help you, then it becomes a lot easier once we get over that hurdle. So if you're treating pain patients and talking to them about this, anything you can do to persuade them, whether that's showing them scans or anything, that's very important. And one thing that I think Howard Schubner does and others, there's a guy in the community in Los Angeles, David Schachter, they do examine the lumbar spinal imaging, like the lumbar MRI, and say to the patient, well, you see where you may have this disc bulge, L4, L5, but you're experiencing pain all up and down your spine and over here on your shoulder and over here. And that just can't possibly explain it. And so that's definitely something that I know people are doing out there.
Okay. Well, one question was really a definition. What do you mean about written emotional disclosure?
Yeah, so that refers to patients writing about stressful experiences, stressful relationships that they have currently, or often we delve into the past, things that they've had in their childhood, relationships with siblings or parents or abuse or trauma. And they write about that experience, and we ask them to write about all the emotions that they have. And there's also a thing called re-scripting therapy that I didn't mention that we employ that's, I think, somewhat related, where we ask them to write the story of a particular experience in different ways. So just write it and then write it as a story, and then write how you might reflect on it now. Write yourself as a child a letter about how you feel now about the experience to try to change the ending. People do this sometimes with dreams, like if they have nightmares, they might write down the whole dream and then change the ending to something healthier, positive, adaptive, so that they go away feeling better about it. So the emotional disclosures is several, written emotional disclosures, several different formats of it. But if that person wants to email me, I can be happy to talk more about it.
Okay, we may need to give them the email again. We can write it in the chat. Okay, and then there are some questions about what is the relationship or difference between ISTDP and EAET?
Yeah, that's a good question. So ISTDP is an individual therapy. It's always been an individual therapy. There are no lessons or homework assignments with ISTDP. It's for a wide range of different presenting complaints and problems, and not just for chronic pain. And it's not time limited. So all of the different EAET models I presented have a certain number of sessions, 1 or 3 or 8 or 9. And ISTDP, really, they say that you keep working with the patient. It's short-term compared to long-term therapy. So it can be up to maybe 50 to 60 sessions, even of ISTDP, that usually, again, involves tries to address multiple relationship issues and symptoms, and go for fundamental character change in the patients. Whereas EAET is briefer and focused on chronic pain and can be conducted in groups and has all of these supplemental materials that we hope the patient continues on their own after completing the time-limited therapy.
Okay. So there are a couple questions that really go back to some of the early anatomical kind of correlations. And one of those really has to do with various emotions being experienced as pain, and asks you, could you speculate that suicidal ideation could be reduced, particularly in teens in this case, but by with this kind of treatment, assuming that that is psychogenic pain, as has been widely speculated?
Yeah, so yeah, I really like that person and that question. So thank you very much. Because that's right up my alley. A lot of what we do is this interplay. What really is emotional and physical? Is there any distinction between those things? And often conceptualizing the trauma and the stress and these difficult emotions, as I tell the patients, this stuff is the pain of your life. This stuff is your pain. And that is what we can focus on to help you. And it is taking a toll, a physical effect on your body. This pain that you carry, on your shoulders, these difficult emotions, all this resentment, anger that you carry, that is what's weighing down your back. That's what's hurting you. And that's the kind of distress. So certainly, I think there are applications for emotional pain specifically, and that kind of distress that goes with suicidal ideation. So if you think about that, and the old thing, there's one of the original defenses from Anna Freud is what they call turning against the self, which is that you're angry at somebody else and you want to hurt them, but that's unacceptable. You feel guilty about that. You're conflicted. It's a moral dilemma. So you turn it back around and end up hurting yourself to reduce that strain, solve that conflict. So absolutely, I think that's a great application. I'd be happy to talk to that person more.
Okay. Well, and I think along those lines, we've got a couple people asking, how do you get trained in this, or is there a certification in this?
Yeah, so I definitely suggest looking at Howard Schubiner's website. Is it unlearnyourpain.com or .org? Just search for Unlearn Your Pain and Howard Schubiner. And he has listed on there a lot of different trainings that he and Mark Lumley and others in this field provide all the time. And there's actually what he calls a Psychophysiologic Disorders Association, which you can get on the listserv to find out about trainings. I don't think at this time there's a formal certification process in EAET. Of course, there is in ISTDP. You can get a certificate saying you're an ISTDP trainer. And I would recommend that International Experience, all these acronyms are not easy to remember. It's IEDTA.org to look for training there. And of course, anybody who's interested, I'm very pleased to speak with them and help them further.
Okay. I'm going to take the prerogative of being the one asking questions. I was intrigued when you were first talking about the moral dilemmas and where that was located. As many of the questions have to do with PTSD. And as you know, one of the big intriguing questions in the VA is, what do you do about moral injury, and how is that experienced and how is that treated? Do you have thoughts about that based on your work?
Yes, I do. So I think Mark Lumley would tell you that one of his main inspirations was noticing there was such an overlap between PTSD and chronic pain in the inspiration for developing this treatment. And in the VA, there was a study published this year, I think it was actually a meta-analysis, that showed that 50% of the veterans with chronic pain also have PTSD. So very high comorbidity. And what Mark Lumley says is that he's observed a wider range of chronic pain patients don't necessarily meet the criteria for PTSD, but they do have similar symptoms. They have hypervigilance, they're keyed up, they've got a lot of emotional conflict that they bring into therapy. And so there are also other overlaps between chronic pain and PTSD. You know, both of them have high rates of alexithymia, which is, you've all heard of that, difficulty identifying and describing feelings. So there are many similarities, and I think an excellent future direction for somebody would be to study EAET specifically in a format that was adapted for PTSD and moral injury.
Okay, and I've been told that this can be my last question. With the ISTDP, a lot of your focus is on defense mechanisms. How do you address defense mechanisms with EAET? The defenses people obviously have are very strong against these emotions.
Absolutely, and I only have 2 minutes to answer that.
Yes, sorry.
So yeah, it's a similar process that we ask the patient to look at a stressful event, and then we ask them, as I mentioned, for emotions, like how did you feel toward that person when they cut you off in traffic? And what we expect is that the patient will respond with a series of defenses. And what we do is we point out those defenses, we bring them into the patient's awareness, say, well, you see how you didn't say how you felt. You actually talked about the other person. And then we call them into question by saying, you see how if you do that, you're missing your feelings. You're missing how you feel here, right? What about you and your feelings? And we try to encourage them to face up to these feelings. And it's typically a process that continues throughout the sessions. But I think the group is great for this, because one patient will usually want to dive right in and start feeling their feelings. They know this is what they need to do, and they'll get benefit, and other patients will see that, and they will then be more open to kind of setting aside their defenses, at least for the session, and feeling some of these feelings as an experiment to see if that helps with their chronic pain.
Okay. Well, thank you very much. We are now at our 11:59 point. So I want to thank you. Brandon, usually the email convention is first name dot last name at va.gov. Is that your email?
Yes, so you're
Okay.
certainly welcome to email me on that VA email address, or I have a MedNet as well, which is bYarns.
Okay.
So happy to speak to anybody, and thank you so much to you, Dr. Stuber, and the Grand Rounds team for getting me ready and inviting me today. Thank you very much.
Thank you. All right.
Bye-bye.
Bye.